So I want you to sort of look at these definitions and think how many of them make sense to you in terms of how you would define moral distress. Is it being compelled to act or not act against your conscience? Is it emotional distress resulting from the death or suffering of patients who you're caring for? Is it emotions experienced when choosing between two or more competing ethical principles? Is it uneasiness or distress when dealing with uncertain outcomes? Is it distress from making a moral judgment about what's in a patient's interest but being unable to achieve it? Now, maybe one of these jumps out at you as the most appropriate definition of moral distress, but I'm going to suggest that all of them lead to a little bit of moral distress, and that being too narrow in terms of the definition actually doesn't help us in terms of understanding what it is. So, or I don't know. So what I'm going to do today is say a little bit, I think I already said this, what is moral distress, what are the sources, how is it manifested, and what can we learn from it, and what are the gaps, what do we still need to do? So starting with something that probably a lot of you know, since many of you have raised your hands, yes, you know what moral distress is, and you've experienced it. The term was first coined by Andrew Judgement, a philosopher who was teaching nursing students at the University of Nebraska. And in the 1980s, he defined moral distress as a very specific niche in the sort of moral landscape of what we do as healthcare professionals, and distinguished it from moral uncertainty and moral dilemma. And uncertainty basically is when you know, something's not quite right, but you don't know what to do. You don't know what the values are at stake. You don't know how to respond. Moral dilemma is probably familiar to many of you when there are two obligations to pursue, and they're both ethically justifiable, but they conflict, and there's no obvious reason to prefer one over the other, and yet choosing one feels like a compromise of the other. And he separated moral distress from both of those and said it's the specific phenomenon that when one knows the morally correct action to take, but institutional constraints make it nearly impossible to pursue it. And it emerged from the experience that the nursing students that he was working with talked to him about. The definition since Jameson's time, since Jameson first coined it, has really expanded, and most people have expanded it in the following direction. They left uncertainty and moral dilemma aside and said distress is really moral distress is really the distress that results when you know what the right thing to do is, but something else is done. And the expansion of definitions over the last 20 years has been really that the constraints are much broader than just institutional constraints. They could include power hierarchies within an institution. It could include self-confidence and self-doubt. They could include lots of things that are not thought of as institutional constraints. So I want to give you a couple of examples. Now, some of these you've probably heard about. These are just some from the literature. The sort of paradigm case is a nurse who disagrees with a physician about what to do. So there might be a child who the nurse believes is very critically ill and needs to go to the ICU, and the physician disagrees. And the child is very sick and does not go to the ICU, and the nurse is taking care of this child. And that sets up a situation of potential moral distress. But there are lots of interesting variations on this theme, so I want to give you some of these from the literature. The first one that I've listed here was actually written about by ethics consultants. They were consulted on a case where there was an elderly woman who had a gangrenous foot, had a number of other comorbidities, was very disoriented and appeared to be in some pain. Her healthcare proxy, who was her daughter, refused to agree to pain medication. She said her mother would not want it. There's no way she would want it, and she didn't want her to have pain medication. And the team had worked very hard with this daughter to try to convince her the mother was in pain. The ethics consultant came in, tried to convince her the mother was in pain. She was adamant, continued to refuse, no pain medication. And the ethics consultant wrote, this created huge moral distress in her because she didn't know how to get past it. There have been a couple of papers that I think are really interesting. One written by some of the people who were involved in providing care to patients in West Africa in 2014, 2015 during the Ebola crisis. And one of the examples that was given about the moral distress was if you're there, you're trying to take care of a patient comes in pretty dire straits, you know you don't have the IV fluids that this patient needs, the electrolytes that this patient needs, and you don't have time because you have a limited amount of time that you can actually stay in the setting, in the suit that you have to wear. And so there was this sort of rapid triage. Some patients just got put in a corner and left there. And that created a huge amount of stress for the healthcare providers because they thought something more ought to have been done. There was a paper that came out, I think, last week in, I didn't write down the journal. Davis is the author, but anyway, it was a study of family healthcare program directors, and it was a description of the moral distress they feel because of the restrictions on their ability to give hepatitis C medications to the patients who have hepatitis C but don't meet the criteria because of the cost limitations. And then there's plenty of examples of decision-making in hierarchies, nurses in the middle. Joe Finns wrote an interesting paper recently on the decline in physician autonomy and professionalism in the sort of corporatization of medicine and how that creates moral distress among physicians. So there's lots of variation in terms of the kinds of stories that people tell that all sound like moral distress. And one of the things that sort of comes up over and over again is this notion of powerlessness. Now, you're in a situation where you think you want to do something different and you can't. And there's lots of reasons why, but that powerlessness is a very important piece of what I think makes people feel distressed. So I'm going to give you a pediatric case I took from the literature because Tricia Prentice actually is a NICU nurse in Australia, I believe, has written a lot of really great papers, I think, on moral distress, and so I recommend her to you. But she talked about this particular case, Mary, a 2-year-old who suffered profound hypoxic ischemic encephalopathy after near drowning. Both the brain MRI and clinical examination are consistent with extensive brain injury likely to result in profound disability. She also has multi-organ failure from the hypoxia, including renal failure. Her parents initially agreed to a goal of comfort care that was suggested by the team, as in Mary's best interest, but then they changed their minds after they talked to one of the consultants, the nephrology consultant. And then they want dialysis and they want full active management of their daughter. This is a not atypical kind of story. I'm certain many of you have had similar kinds of debates about what's in the best interest of a particular patient, and either the family or some of the other clinicians on the case disagree with you. What's interesting about it is it's a very typical example of, and this is my schematic, but basically the ingredients that people sort of seem to always have in this idea of moral distress is make a judgment, the action that's taken is not compatible with the judgment. There's a constraint in the middle, and that leads to moral distress. Why does it occur? I think I've already gone through this, lots of different sources. And it seems to be at least growing in recognition. So this was a paper in New York Times article a couple of years ago, Pauline Chen wrote. She said, you know, doctors and nurses feel trapped. They feel trapped by the competing demands of administrators, insurance companies, lawyers, patients, patient families, and even one another, and forced to compromise what they believe is right. So this is the sort of, again, description of moral distress that's very common. So I want to take a minute to think about what these constraints are and go from there. So we already talked about Andrew Jamieton's earliest definition was institutional constraints, and so there certainly are, you know, there are policies, there are laws, there are costs, there are things like that that are very difficult to say what to do about. I mean, they exist, and you've got to deal with them. But there's also this whole focus on the internal or personal factors that lead to or contribute to, maybe, moral distress, including lack of knowledge, lack of confidence, fear, maybe fear of losing one's job, perceived or even real powerlessness, self-doubt, anxiety about creating conflict. And you can see stories that exemplify this kind of source of moral distress in lots and lots of cases. It seems to me sort of readily apparent that the way to address these might be different than the way to address the structural or institutional constraints on moral action. And so if it's institutional constraint that has to do with decision-making hierarchies or power differentials or lack of administrative support, or resources or policies, that's a different kind of approach in terms of how to address it. I'm actually going to skip this case because it's very much like the Mary case. It's just different details. But basically the story here is another baby whose parents want aggressive, full-out care, or in this case a mother, and the team thinks that's the wrong choice. And the team feel that the care is inappropriate for this baby, and they feel like they're torturing the baby. And that's a sort of part of this distress phenomenon. But the reason I wanted to say it is I think that this sort of inappropriate care category is really the biggest category of source of moral distress. So there have been a couple of really interesting studies. And I'm going to show you just 3 of them. This one was done in ICUs in Europe and Israel, and it was doctors and nurses in the ICUs were asked, on the day that they were taking the survey, did they think there were any patients in their care that were being treated inappropriately? So on that single day. And the results were that about 30%, 27% overall, said yes, that on that day they were taking care of patients that they thought were receiving inappropriate care. And the vast majority were over-treatment in this case. Now these are ICUs, and so you can talk about the details, but a similar study was done later, I think in a very similar design, in California, in ICUs in California. Again, the same sort of sample size, about over 1,000 nurses and doctors in ICUs in California, asked the same question. On the day that you're completing the survey, are there any patients in your care that are receiving inappropriate care? And again, here the number is about a third, a little higher. 38% said yes. I am giving inappropriate care to about 30%. 30% of us are giving inappropriate care today. And again, most of it was perceived by this cohort anyway as too much care, overcare. And some of it that, the ICU was inappropriate for this particular patient. I think this is a common thing. There was an older study, slightly smaller, 780 people, published in 2005 with pediatric professionals, nurses, attendings, and health officers. And one of the things that this study did, which I found very interesting, is that they tried to compare subspecialties. So they compared critical care with hem-onc, with other specialties, and found some differences in terms of the responses. But basically, you can see the numbers that I pulled out in the sort of orange balloon here. Of the nurses, attendings, and health officers in 7 U.S. hospitals in the early 2000s, and this was not, the question here was not today, the day you're filling out the survey. The question was more at times or sometimes. It was much more vague in terms of have you ever kind of questions. So have you ever acted against your conscience? And, somewhere between 25 and 50% said yes. Have you ever saved children who you thought should not be saved? Between 35 and 80% said yes. Have you ever given up on children too soon? Some said yes, a much smaller number, 2 to 8%. And have you ever offered treatments to children that are overly burdensome? And again, 31 to 66%. So you see the theme. There's a sort of sense among healthcare providers in certain settings, asked in different ways, that they're giving inappropriate care to the patients that they're taking care of. And that's a huge source of moral distress. Now, I mentioned that moral distress, the definition came from Andrew Jameton when he was working with nursing students, and I think sometimes people still think this is something that nurses experience. But in fact, there's been tons of papers and studies that have showed almost every healthcare profession that you can think of has an experience or has experienced something that looks an awful lot like moral distress. Now, they may not call it all moral distress, but they certainly experience it. And in fact, if you look across disciplines, you might find that the sort of sources or the actual experience are slightly different, and that's because role responsibilities are different. But everybody has this sort of, not everybody, every healthcare professional group has expressed some experience of thinking they know the right thing to do and not being able to do it for a variety of reasons. And I think this list is just growing. Dr. Silver mentioned our book. Shameless self-promotion here. This is a copy of our book, what we tried to do in the book was invite people from a variety of healthcare professions to talk about their experiences with moral distress. And so that's what the book is about. And that included cross disciplines within the United States, but also people from around the world. So I think it came out pretty well. So what happens with moral distress? Now, there's lots of studies that have documented that people feel angry, frustrated, guilty, lose self-worth, get depressed, resentment, anxiety. They have physical symptoms like headache and neck pain and insomnia. And basically they're suffering, and it shows up in physical and psychological symptoms. And people have documented as well that this then leads to a couple of not so good outcomes, like numbness to ethically challenging situations where people no longer want to engage with them because they don't want to feel that kind of distress, or they withdraw from care, or the care of a particular patient, or the care of a particular type of patient, or there's burnout and decreased job satisfaction. And some people have been documented to actually leave their profession, they leave their job. And, you know, there are lots of things going on in healthcare. Certainly, this could contribute to, moral distress could contribute to some of this dissatisfaction and burnout. But I want to remind us all that not all sadness or anger or frustration is moral distress. I think everybody knows that, but sometimes it's worth pointing out. You know, when you work with children who are dying, that's really sad, and it's really hard. Doesn't mean it's moral distress. You can be distressed, you can be sad, you can be angry at the parents, but you can feel like everything possible that could have been done to make this a good death for this child was done. And then there is no moral distress. That's the distinction I would like to make. Same with stress itself. You know, work as a healthcare profession can be hard and busy, and, you know, we don't have time to stop and have lunch half the time. Stress and distress are part of the job, but it's not all moral distress. I mean, you can have a situation where, you know, everything went fine and you're still stressed out. That's not moral distress. On the other hand, there's plenty of evidence that moral distress is not only ubiquitous, but might be growing. Now, it might be growing in terms of recognition as opposed to growing in experience, but it's certainly being recognized as pretty pervasive across settings, across disciplines, across time. And a particular emphasis in recent years about, you know, the sort of healthcare settings where the priorities seem to have shifted away from patient care to patient throughput, or in this one quote that I have here on that. So I want to turn now to what have we learned and where are we going to go forward, and recognize that in the last 10 years, let's say, there's been a shift in the scholarship on moral distress. So all of what I said has been sort of going on for a while, but there's been three sort of ways in which people who have been talking about, writing about, and studying moral distress have sort of shifted. And these are the three. There's one group of people who have said, we should abandon this concept. I'm going to tell you a little bit why they say that. There's another group who have said, no, we need to clarify it. We also maybe need to expand it. It needs to include more than the sort of narrow view of what we thought it was before. And then there are a growing group of people who are promoting the investigation of strategies to minimize constraints, but also to maximize agency and resilience. So why abandon the concept? Well, some people have argued since healthcare providers do respond to morally charged situations by doing, I'm messing up. So let me start again and read on my slide and stop talking off the top. Since many healthcare providers do not respond to morally charged situations by doing nothing or by doing the wrong thing, the focus on moral distress is disproportionate, and in turn undermines the important work on ensuring moral competence of individuals and institutions. And so instead of talking about moral distress, we need to focus on and improve the quality and safety of moral decision-making and conduct, and devise mechanisms, evidence-based mechanisms for addressing and preventing moral conflict and developing moral competence. One of the themes about abandoning moral distress goes back to what I said before, that some people think this is just nurses complaining. And it isn't just nurses complaining, but some people think it's just nurses complaining, their work is hard, and, you know, they should get over it, basically. And that's really both unfair and untrue, but also a reason that we either need to talk about moral distress for what it really is, or maybe we should abandon the concept and talk about something in a more constructive way. Some people even claim, although I haven't seen any evidence of this, that the whole discussion of moral distress in nursing has turned people away from wanting to be nurses, from entering the profession. I'm more of the camp, I believe, that is focused on trying to clarify and expand and learn from moral distress. And I think that is based on my belief, and many others, that moral distress actually is a very real phenomenon. It names experiences and validates experiences that people actually are having, and could represent an underappreciated hazard in healthcare, that people are experiencing it sometimes without an outlet. And so if we can clarify when it occurs and address it, we can help people in a number of ways: promoting moral competence, reducing threats to moral integrity, minimizing moral distress, or using them as opportunities for resilience and growth, motivating system changes, and improving work environments. So I want to go back to my little schematic and say, how can we sort of address this by thinking about the different parts? Let's talk about the different parts of this paradigm, starting with moral judgment. So the paradigm is a person makes a moral judgment and then a different action is taken. But one of the things that hasn't been well studied is, what's the basis for the moral judgment? How well informed or well justified are the judgments that people are making or they think they're making? Do they have all the facts? Do they have the sort of nuances of what's going on? Could they be wrong about their moral judgment? And I think any of us, all of us, who have made moral judgments in our life know there's little that's black and white, right? A lot of it is sort of mushy. And so being certain that this is the right thing to do, I think is fairly rare and sometimes misinformed. And so we have to really ask ourselves about what's the basis for judgments? Are they informed, well considered? We also have to think about, once somebody makes a judgment, how well are they articulating it or communicating it to the others on their team or the relevant others? And this is not a trivial matter. I mean, people sometimes, I think often, may have in their mind, this is the right thing to do, but I don't know how to explain it. I don't know how to explain it to somebody else. And so I just keep quiet. I think maybe I'm wrong. Maybe I'm not smart enough, or I don't have enough information. So I don't say anything. And then I feel bad because I think I had the right thing to do and I didn't tell anybody and something else was done. So working on communication, environments where it's okay to express yourself even if you're not sure. That's not something we do well in general, and support for discussion. And as many people have pointed out, and those of us who work in ethics know, moral disagreement can actually be very healthy. It can get all of us clearer about what the right thing to do is or what the options are. So how do we address these issues of judgment? We need more ethics education and mentoring to develop moral competence and resilience. We need ethics resources available to staff and patients. I don't know if some of you know that Heather Fitzgerald at Children's Hospital in Denver has started this program that she calls Ethics Champions, where it's a competitive process, but there are people from each unit in the hospital apply to be the ethics champion for their unit. And then they have a series of educational programs and support groups and things like that, so that the person who's there on the unit all the time, every day, can be the sort of go-to resource for ethics. And it's been so successful in her institution that 2 other institutions have adopted it, the Children's Hospital in Kansas City and Atlanta. Environment supportive of addressing ethical concerns promptly and openly in multidisciplinary teams. Again, this is something like, we all say this, but we all know how hard that sometimes is to do. And then ethical climate. Ethical climate has gotten a lot of attention. What is an ethical climate? It's a climate in which people feel respected for their contributions, in which the policies and the resources are designed to help people do their job well. And do their job well is take the best care of patients that they can. There are lots of interesting studies that have looked at the correlation between moral distress and ethical climate. The better the ethical climate, the less moral distress in those environments. What about studying constraints? We can address them in different ways. Now, certainly we know, or we should know, that constraints vary both in type, as I've already mentioned. Some of them could be internal, some of them could be institutional or structural, and approaching those has to be different. But they also vary in degree. And there's an interesting taxonomy that Thomas and McCullough published in 2015 in the Journal of Medicine and Philosophy, where they distinguished what are challenges to moral integrity, threats to moral integrity, and violations of moral integrity, and that they can be distinguished in certain situations, and they described a situation, which I'll tell you about in a second. In the same situation, it can escalate from a threat to a violation. And the story that they told was about a team in an ICU, a person who, I forget his diagnosis, but anyway, had an arrhythmia. They called the family to come because they were worried about what was going to happen. The patient arrested, the family arrived and was ushered into the waiting room. And so 2 members of the team disagreed on how quickly to bring the family in. The nurse said, we need to get the family in here right away. The resident said, well, we have a bunch of interns in here, we need to practice compressions. And that, as I understand it, is something that happens in teaching hospitals. That you need these opportunities to practice doing compressions. But the longer that went on, the more the distress rose to the point where it ultimately, as the description was written, the person had to decide, was she going to just physically interfere with ongoing compressions, leave the room, or sort of jump up and down and scream in a way that made it impossible for anybody to go on. And at that point, Thomas and McCullough said it was a violation of her integrity. So what can we think about as strategies to address constraints? Certainly leadership. Leadership committed to supporting ethical practice and supporting the well-being of healthcare providers, a really important thing. And I know there's wellness programs developing in lots of healthcare facilities, including here, I understand. Ethical climate, which I've already alluded to, which really requires a little bit of studying. What is an ethical climate? How do we promote it? How do we create it? How do we support it? How do we keep it, maintain it? Support within institutions for judicious recusal. And I say judicious because recusal of taking care of a patient should be allowed in certain cases, but it has to be really well thought through, and there needs to be other mechanisms in place to be able to make sure that the patient doesn't suffer. And then, in some cases, collective action to change policies, to change structures. What about the actions themselves? So I'm going back through that paradigm. Moral judgment, constraints, action. So, as I already alluded to, healthcare providers can and do act in accordance with their moral judgments. We need to know more about those. We need to examine those. We need to describe those. We need to say what makes people able to do that in certain cases, as well as examining the subset of cases where they can't and understanding more about why. We also need to examine the actions themselves. Sometimes an action, if I make a judgment, this is what I would do, and something else is done, it could be that that action is still perfectly legitimate and appropriate. It just isn't what I would have done. And so understanding the actions themselves is an important part of sort of figuring out how to address this problem. It's also true that, as I, again, already alluded to, some actions are controversial. They may be morally legitimate or acceptable, but they're still controversial. And so being able to name that and say, this is a controversial decision, this is what we did, this is why we did it, still helps people understand, well, okay, maybe that's not so terrible after all. But then there are some actions that probably are clearly wrong, and we need to know those too. So what kind of strategies can we use to understand actions? We can look at clarity and transparency about decision structures. Who makes the decisions in different cases? How are they made? What are the contributions of the various members of the team on any decision about a patient? Ethics resources for voicing concerns and resolving conflicts. Communications during and after events. I say debriefing here, I'm thinking of things like Schwartz rounds, which I know you guys do here. This is something that many hospitals are beginning to do, and it's a way for people to debrief, basically, about a situation. Some of these are repetitious from my other slides: supportive organizational policies, healthy work environment, quality improvement activities, and challenging the status quo. And then we get to the last thing on the paradigm, the moral distress. So I think we need to understand distress better. People talk about it as something that chips away at one's moral integrity. But now we're also talking about resilience, moral resilience. And I want to talk about moral strength and moral success, because I think those are all part of the paradigm as well. So one thing about distress is that, and I believe this is true, that experiences of moral distress do go beyond the current definitions, which is why we need to rethink these definitions. I think it is true that people feel distress in situations of moral uncertainty. And I would call that moral distress. They don't know what to do. They feel really caught because they don't know what to do. I think sometimes people feel distressed when the action matches the judgment, when in fact the action taken is exactly what you thought should be done, but it's still distressing. There was a very interesting paper in JAMA, I don't know, a couple of weeks ago, about a resident who was taking care of a patient who needed recurrent paracentesis, and talked about the amount, how carefully he calculated the amount of volume he was able to take out before causing really serious problems in this patient. And then he went one day and the patient asked him, take it all out. And he talked to the patient a little bit, he talked to the family member a little bit, and the patient meant it. He was done. He wanted to die. And the resident said, I can't do that. I can't do that. And so he did the procedure in the way he normally did. His action matched his judgment, believing that that's the way he ought to do it, and he felt terrible about it. So that's distress, right? That needs to be addressed. I think we feel distress in moral dilemmas. When we have a challenge between honoring the parent's wishes and it seems to not comport with what we think is best for the child, those are two really important principles that we need to deal with. And it's not easy to decide which one to do in many cases. That causes distress. And that's a dilemma. And I think we need to think of distress as an opportunity. And that's where I'm going to turn now. I'm going to get that. So one of the things that's come up in recent literature is moral distress inevitable? And the answer is maybe. But is it always negative? And the answer is probably not. And so this is where I want to go. Tricia Prentice, again, I mentioned earlier, did a study of NICU nurses and doctors and asked them, was moral distress inevitable? And basically, most of them said, yes, it's inevitable. In a place like the NICU, where we have seriously ill kids, life and death decisions, lots of uncertainty and disagreements about, in terms of backgrounds and values and et cetera, it's inevitable. Of course we're going to have moral distress. Of course we're going to have situations that are very difficult to resolve. But then they went on to say, but that's not inevitably a bad thing. So here are some of the quotes from their study. Moral distress can be a useful precipitant to informed decisions, leads to the best course of action or the best outcomes. If we removed moral distress, we would be like robots, no hearts, no feelings for babies and families. Moral distress results from practitioners actively questioning care decisions and practices. That's important. We should be doing that all the time. Important to providing optimal care. And if one, I love this last one, if one does not experience moral distress occasionally in our environment, they should not be working with our patients. Pretty firm and probably true. There are others, in addition to this study, that have recognized the sort of energizing aspects and the positive aspects of some distress about a situation, about a patient care situation. So Lutzen, who's written lots about moral distress, said years ago, stress can be energizing. John Lantos has written, I think, eloquently about this. He says, you know, moral distress and ethical confrontation are sometimes a good thing. They show that people are aware of what's going on and that they're struggling and trying to talk to each other about how to do it right. And so I think what we can think about is that moral distress can either indicate or promote awareness, reflection, and can be an opportunity for people to grow and learn from. So, you know, the sort of narrative in the literature is that it's always compromise or residue or chipping away at integrity. I think those do happen, and so we can't ignore that that's a possibility, that there are situations where you feel like you have compromised yourself, and that is a really awful feeling. And there are situations where you're constantly going back and experiencing this distress in the same way for the same reasons, perhaps, and that does create a residue that's hard to get rid of. But at the same time, certain cases of moral distress, can lead to resilience, and we should be capitalizing and learning how to do that. So there's been I don't know how many of you know Cinda Rushton. She was here for some years. She's written a lot, and so have others, about this concept of moral resilience. And in one paper, she described what we need is a widely used phrase to describe the positive outcomes of morally distressing situations. So it's what we've been talking about, that there's, you know, if somebody doesn't have a little bit of distress in the NICU, you don't want them there. You want the people who struggle, who work together, who try to find the right outcome, and there are ways to do that, and there are positive outcomes from that experience. She describes resilience as the capacity of an individual to sustain or restore their integrity in response to moral complexity, distress, or setbacks. Others have written similarly, the ability and willingness to speak and take right and good action in the face of moral adversity, or Monteverdi wrote, it allows a person to reframe a moral situation into a challenge over which she has a level of control. How do we promote resilience? I don't think we really know yet. I think we're working on this, but I think this is where we should be directing our attention. Certainly ethics education, certainly self-care of healthcare providers. There was a publication last week in JAMA on a charter for physician well-being, which has very specific, here's what we should be doing to promote physician well-being. And in the ANA Code for Ethics, there's a particular number 5 that talks about the nurse needs to take care of herself as much as everybody else. We should be fostering hardiness, whatever that really means. I mean, people write this in the literature, hardiness and meaning, in our work, ethical climate again, think of ways to reward good decisions, reward good actions, reward moral strength and moral success, and be creative. Bob Trug, who some of you know, wrote in the book that we published about how he feels like they've been creative in reducing moral distress in the particular circumstance when a family wants a code on a very seriously ill child that the team thinks that the code will do nothing. So they have adopted a process where they do a code, but they do a very limited code. Now, that's a controversial solution, but it's a solution that he describes as a way to reduce, to take into account the family's values, the family's needs, the family's preferences, and do something that also allows the team to reduce their own stress. To end, I want to talk about what I have loosely called moral success. So I think moral success is slightly different than moral resilience, because the way that people have been talking about it. Resilience is this idea that you experience a stressful situation and you're able to learn from it and grow from it and come out more positive than compromised. But I think there's a whole other piece of this that we have not paid enough attention to, and that is the sort of everyday decisions that healthcare providers do make that have moral dimensions, where they do voice their concerns, where they do act in accordance with their moral judgments, or they do work out with other members of the team. How do we come to some agreement about how to proceed here? This happens all the time. And so we need to understand this better to say, here's why it happens, and here's why it doesn't happen. Or here's when it happens, and here's when it doesn't happen. So, in closing, what have we learned? Moral distress is an important phenomenon among a wide array of healthcare providers. Disagreement about ethical issues and actions in healthcare may be inevitable and may lead to distress, but does not inevitably lead to compromise of moral integrity. Moral distress may present opportunities to improve the quality of the ethical decisions that we make, to change the processes that we use to make them, to improve institutional structures that support our making good moral decisions, and may give us opportunities to learn and grow. We do need more attention. We need more research. We need to pay more attention to how do you promote moral competency among healthcare professions? How do we prepare healthcare professionals for the ethical challenges that they are going to face and that keep changing? How do we identify and address the constraints that do challenge people's moral integrity? How do we examine the choices and the actions that are taken in complex situations? What resources do we need to mitigate distress, moral distress, and to enhance well-being? How do we strengthen ethical climates? How do we capitalize on the potential for growth, resilience, and learning? And how do we investigate the daily more successful moral decisions and actions of healthcare providers? I want to end noting that today is the 50th anniversary of the death of Martin Luther King, and he said something in the speech that he gave 50 years ago last night, which I thought was appropriate here. The description that I read was that, the arc of the moral universe is long, and it may bend toward justice, but human progress has never been linear. It zigs and zags. And he also said, whenever men and women straighten their backs up, they're going somewhere. Because a man can't ride your back unless it's bent. So thank you very much.